Bismillahirrahmanirrahim. Quote of the day: Raise your words, not voice. It is rain that grows flowers, not thunder. Assalamu alaikum, everyone. Today, the topic of my presentation is hemoglobinopathies, and I am presenting it under supervision of my professor, Dr. Saram sir. Learning outlines: Introduction to hemoglobinopathies, Introduction to sickle cell disease, cause, types, symptoms, complications, inheritance, management, Introduction to thalassemia, variants, clinical features, management and prevention, screening of hemoglobinopathies, and recent updates and MCQs in the end. Learning outcomes. By the end of this presentation, participants would be able to describe the most common hemoglobinopathies, their variants, management, and prevention. Now, what is hemoglobinopathy? It is a kind of genetic defect that results in abnormal structure of one of the globin chains of the hemoglobin molecule. Hemoglobinopathies are inherited single gene disorders. So it could be of two types. If unusual genes that affect the quality and structure of hemoglobin, then it leads to hemoglobin variants like hemoglobin S, that is sickle cell disease, and hemoglobin O and E. And the other is if unusual genes that affect the quantity of hemoglobin, resulting into thalassemia. Now, first we'll discuss about sickle cell disease. In sickle cell disease, the beta chain is affected by mutation that results into a formation of an abnormal hemoglobin called hemoglobin S, and it is formed by a point mutation in which glutamic acid is substituted with valine at position 6 in the beta hemoglobin chain gene. It affects millions of people throughout the world and is particularly common among those whose ancestors came from sub-Saharan Africa, South America, Caribbean, Central America, Saudi Arabia, India, Mediterranean countries like Turkey, Greece, and Italy, and it can be very well appreciated in this in this picture map. An estimated 3.2 million people in the world have sickle cell disease, with about 80% cases occurring in Africa. And the fact about it that it occurs more often among people from parts of the world where malaria is or was common. It is believed that people who carry the sickle cell trait are less likely to have severe forms of malaria. In Pakistan, about 0.5 to 1% of Pakistani population carries hemoglobin S or hemoglobin E. Nevertheless, the exact prevalence is not established. The normal hemoglobin has the following types: hemoglobin A, A2, hemoglobin F. Hemoglobin F normally predominates in the first year of life, and after that hemoglobin A predominates. That is 96% is hemoglobin A, and 2 to 3% is constituted by hemoglobin A2. Types of sickle cell disease. These are following: like sickle cell anemia. It is a homozygous form in which both hemoglobin are hemoglobin S, and it is the severest form. Then comes sickle cell trait. It is heterozygous with half of the hemoglobin being normal and half being sickle hemoglobin, and no symptoms unless under low oxygen tension. Then comes sickle cell beta thalassemia. It is heterozygous form but with the concentration normal hemoglobin being higher than sickle hemoglobin, and it is milder form. Then comes hemoglobin SC disease, in which there is no normal hemoglobin and the presentation is similar to sickle cell anemia. It's the second most common type of sickle cell disease. Genetics of sickle cell disease. The change in cell structure arises from a change in the structure of hemoglobin. A single change in an amino acid causes hemoglobin to aggregate. As we can see that there is substitution of glutamic acid by valine. Inheritance of sickle cell disease. If one parent has sickle cell trait and the other is absolutely normal, then there is a chance that 50% of their children will be a carrier, and 50% will be normal. And if both parents have sickle cell trait, then there is 1 in 4 chance that the child will be normal, and 1 in 4 will be a sickle cell anemia, and 50% of the children will be a carrier. And if one parent has sickle cell trait and other has sickle cell anemia, then there is 50% chance that there is 50% chance that the children will be a carrier, and 50% chance that the children will be sickle cell anemic. That is, no children will be completely unaffected. And if one parent has sickle cell anemia and the other is completely affected, then all children will be having sickle cell trait and none will have sickle cell anemia. Pathogenesis. When sickle hemoglobin gives up its oxygen to the tissues, hemoglobin S sticks together, forms long rods, rigid, inflexible, and sickle-shaped RBCs, which are unable to squeeze through small blood vessels and leading to blockage of small blood vessels, less oxygen to tissues of the body. So RBCs containing hemoglobin S have a shorter lifespan. That is normally there's 20 days, and it is a chronic state of anemia. Uh, Here, this is a picture. We can see these are the normal RBCs, and this is shaped RBCs. Symptoms and complications. It leads to cerebral infarcts, leading to stroke, mental retardation, pulmonary infarcts, leading to pneumonia, splenomegaly, leading to splenic atrophy, infarcts of the extremities, vasocclusion, ulcers, osteomyelitis, retinopathy, congestive heart failure, and renal infarcts. Chief cause for admission of patients in sickle cell crisis, it includes vaso-occlusive crisis, which is further divided to pain crisis, panic sequestration, acute chest syndrome, aplastic crisis, and hemolytic crisis. Factors that can precipitate sickle cell crisis are infection, low oxygen tension, dehydration, acidosis, extreme physical exercise, physical or psychological stress, alcohol, pregnancy, cold weather. Now, vaso-occlusive crisis, it occurs due to obstruction of microvasculature by rigid sickle cells. Painful crisis, it can affect any part, but it's chiefly experienced the abdomen, bones, joints, and soft tissues. It starts suddenly, very severe, and it may last for several hours. Commonly, long bones are affected, but in the first 18 months can involve metatarsals and metacarpals causing dactylitis, which is the painful swelling of hands and feet. Then comes splenic secretion. When vasocclusion occurs in the spleen, the microvessels block and blood accumulates in the spleen. It causes rapid enlargement, which is a life-threatening medical condition. It is common in the first 5 years of life, may cause splenic infarction, which is autosplenism at the end of childhood. And sequestration causes worsening of baseline anemia, increased risk of infection by encapsulated organisms like Haemophilus influenza, Streptococcus pneumoniae, Staphylococcus and Neisseria meningitidis. Acute chest syndrome, it is characterized by chest pain, fever, cough, tachypnea, pulmonary infiltrates, hypoxemia, and it is a medical emergency which is commonly precipitated by chest infections in children. Aplastic crisis, it is the worsening of baseline anemia due to infection of parvovirus B19. Then comes hemolytic crisis, which is accelerated breakdown of RBC that occurs with coexistence of G6PD deficiency. Now, the sickle cell anemia's diagnosis is made by family history and clinical manifestation, newborn screening, lab tests, which includes increased retic count, decreased hemoglobin, hematocrit, and TIPC, hemoglobin electrophoresis, which reveals hemoglobin S, and normocytic, normochromic sickle shape cells in normal MCV, MCH. However, there is normal serum iron and serum ferritin in sickle cell anemia. Treatment is usually aimed at avoiding crisis, relieving symptoms, and preventing complications. Babies and children under 2 and younger with sickle cell anemia should make frequent visits to doctor. Children older than 2 and adults with sickle cell anemia should see a doctor at least once a year according to the CDC. Treatments might include medications to reduce pain and prevent complications and blood transfusion as well as bone marrow transplantation. Medications. Antibiotics. Children with sickle cell anemia may begin taking the antibiotic like penicillin when they are about 2 months old and continue it till their age of 5. And doing so, it prevents infections like pneumonia. Then comes pain relieving medications. Then hydroxyurea, which when taken daily reduces the frequency of painful crisis. Assessing stroke risk, vaccination to prevent infections. Childhood vaccinations are important for preventing disease in all children. Vaccinations such as pneumococcal vaccine and annual flu shot are important for adults with sickle cell anemia. Blood transfusion, nitric oxide, because the people with sickle cell anemia, they have very low levels of nitric oxide in the blood, and people with sickle cell have low levels of nitric oxide. So bone marrow transplant or stem cell transplantation, it offers the only potential cure for sickle cell anemia and in the last gene therapy. Infections in sickle cell disease, it is the most common cause of death in children but a major problem at all ages. Due to splenic dysfunction from sickle damage, it occurs from few months of age, especially with certain bacteria. infection may be rapidly overwhelming, and prevention is done by education, penicillin, and vaccines like pneumococcal, Haemophilus influenza, and meningococcal vaccines, travel prophylaxis for malaria endemic areas, and aggressive treatment of infections. Now, moving on to our second hemoglobinopathy, that is thalassemia. Globally, thalassemia is the most prevalent yet preventable genetic blood disorder affecting populations in Mediterranean area, Middle East, Central Asia, Indian subcontinent, and Southeast Asia. It affects approximately 4.4 out of every 10,000 live births throughout the world. Advances in thalassemia care and management, combined with the commitment of governments in many parts of the world, have transformed it from a childhood fatal disease to a chronic disorder requiring multidisciplinary care incompatible with normal life expectancy. However, unfortunately, this is not the case in Pakistan. Introduction. It is a genetic disorder resulting in a mutation or deletion of the genes that control globin production. Normal hemoglobin is composed of two alpha and two beta globins, but mutations in a given globin gene can cause a decrease in production of that globin, resulting in deficiency, and aggregates become oxidized, damaging the cell membrane, leading either to hemolysis, ineffective erythropoiesis, or both. Thalassemia classification, it is predominantly divided into alpha thalassemia and beta thalassemia. Beta thalassemia is further divided into thalassemia major, intermediate, and minor. Alpha thalassemia, it is the most common type, and it occurs when a gene or genes related to alpha globin proteins are missing or changed, and alpha globin chains are absent or reduced in this type of thalassemia. Alpha trait, that is heterozygous state, is asymptomatic in about 30% of African Americans, and it occurs most often in people from Southeast Asia, Middle East, China, and those of African descent. Alpha thalassemia variants, these are alpha thalassemia's silent carrier, which is asymptomatic. Then comes alpha thalassemia trait resulting from the deletion of two out of four genes. And it is asymptomatic. However, small pale RBCs may be found in the CBC and mild anemia. Then the third variant is hemoglobin H disease, which occurs due to deletion of 3 out of 4 genes, and it is moderate to severe hemolytic anemia, modest degree of ineffective erythropoiesis, splenomegaly, and variable bone changes. The fourth variant is alpha thalassemia major, which is also known as hemoglobin bars, and it occurs due to deletion of 4 out of 4 genes and causes non-immune hydrospitalis, and it is usually fatal. Then comes the second type, that is beta thalassemia. When similar gene defects affect the production of beta globin protein, beta globin chains are absent or reduced, and it occurs more often in people of Mediterranean origin. Chinese, Asians, and Africans are less affected. Beta thalassemia in Pakistan. It is one of the most inherited disorder in the country, with a prevalence rate of 5 to 8% in the Pakistani population and birth of 5,000 major children every year in the country. There are more than 50,000 thalassemia patients registered with associations and treatment centers all over the country. These are the different variants of beta thalassemia trait, beta thalassemia intermedia, and beta thalassemia major. With thalassemia major, the child born with thalassemia major has two genes for beta thalassemia and no normal gene, and it is homozygous for beta thalassemia. It causes a striking deficiency in beta chain production and the production of hemoglobin A. Treatment includes chronic blood transfusion therapy, iron chelation, splenectomy, allogenic hematopoietic transplantation. Then comes thalassemia intermedia, which is milder than major variant, and the signs and symptoms appear in early childhood or later in life. Affected individuals have mild to moderate anemia and may show slow growth and bone abnormalities. Then comes thalassemia minor. It is caused by heterogeneous mutations that affect beta globin synthesis. It is usually present as mild asymptomatic hemolytic anemia unless patient is under stress such as pregnancy, infection, folic acid deficiency, and these have one normal beta gene and one mutated beta gene. It usually doesn't require treatment. However, patients are made sure that they are not diagnosed with iron deficiency anemia. Inheritance. If both parents carry normal or healthy beta globin genes, then all children will be healthy. However, if one of the parent carries an affected beta globin gene, she is a beta thalassemia carrier, then 50% of the children will be healthy and 50% will be a carrier. And if both parents carry the beta thalassemia rate, then 50% will be a carrier, and 25% of the children will be with thalassemia, and 25%, that is 1 in 4 of the children, would be healthy. Diagnostic evaluation. It is done by history collection, physical examination, which reveals splenomegaly. CBC reveals microcytic hypochronic anemia. Peripheral blood smear, in which RBCs will appear small and abnormal in shape when looked under microscope. Hemoglobin electrophoresis, which shows the presence of an abnormal form of hemoglobin. A test called mutational analysis can help detect alpha thalassemia. Amniocentesis, molecular diagnostic test can determine whether mutation is present after 8 weeks of gestation. Management, medical management. Thalassemia minor usually does not require treatment. For thalassemia major, the treatment goals are to provide adequate normal hemoglobin for erythropoiesis and to alleviate the effects of iron overload, or its treatment goal involves regular blood transfusion and folate supplements. During blood transfusion, the client should take iron supplements. Chronic transfusions are administered to correct anemia with targeted hemoglobin level at 9 to 10 milligram per deciliter. Iron chelation with deferoxamine is necessary to prevent iron overload by removing excess iron from body, and genetic counseling and testing for families should be encouraged. Surgical management includes bone marrow transplantation and splenectomy. So available therapies to cure thalassemia: blood transfusion, drugs like hydroxyurea, stem cell therapy, and gene editing. Prevention efforts. It includes premarital screening to make sure that the couple are not both carriers, provision of counseling and health education for the thalassemics, their families, and the public, provision of prenatal testing for thalassemia, reduction of marriages between relatives. Prenatal diagnosis and prevention. The birth of beta thalassemia major child can be prevented. Couples who are aware they are carriers of beta thalassemia may undergo prenatal diagnosis like amniocentesis, chordocentesis, chorionic villus sampling to prevent the birth of an affected child. The prenatal diagnosis method used in Pakistan is chorionic villus sampling. Hemoglobinopathy screening. Hemoglobinopathy screening programs like newborn screening identify which individuals have sickle cell disease or thalassemia, and correctly screening for these hemoglobinopathy is important to help individuals and their families get connected to healthcare services, treatment, and support groups to help manage the condition and improve long-term health. So there is a Thalassemia Federation of Pakistan. It is the umbrella organization of all societies working for thalassemia in the country. Its aim is to provide the associations nationwide with any assistance they need to provide all the required support, including treatment and prevention services to thalassemics and their families. Recent updates. Punjab Thalassemia Prevention Program. Punjab was the only province that has taken a lead to initiate a public sector prevention program in 2009 as Punjab Thalassemia Prevention Program. The government has decided to enhance the scope of this project to the other genetic conditions as well, and therefore the project has been converted to regular institute under Fatima Jinnah Medical University from July, and title is Punjab Thalassemia and Other Genetic Disorder Prevention Research Institute. The scope is to provide prevention screening services for thalassemia and other genetic conditions across Punjab, and provide services of premarital screening, general population screening, extended family screening, and most importantly, prenatal diagnosis of beta thalassemia. The beauty of this program is that it provides all the services free of cost. So it is being a blessing to the poor families affected with beta thalassemia. This is the snapshot taken from its website. This is the homepage of Punjab Thalassemia Other Genetic Disorder Prevention Research Institute, and it's providing genetic counseling, carrier screening, prenatal diagnosis. Then this is article titled as Thalassemia in Pakistan Current Status. Pakistan is among the highest thalassemia burden countries in the world. The commonly quoted figure for the country is 100,000 transfusion-dependent thalassemia patients. But in the absence of coherent national policy and strategic plan, the number of thalassemics in the country is believed to be increasing, but the exact burden of disease is unknown. As a result, despite being a preventable blood disorder, this in Pakistan continues to increase in number and causes misery to the patients and their families. So, as no baseline survey has ever been conducted in Pakistan, there are no credible stats about any aspect of thalassemia in the country. Basic epidemiologic and clinical data about Pakistan thalassemia population do not exist. Information is also not available about treatment facilities and their access to the patients. Without the basic information, it is difficult to convince the policymakers about allocating resources to control and prevent the thalassemia. Then this is another article titled as COVID-19 pandemic and hemoglobin disorders. According to it, the SARS-CoV-2 infection may trigger such a serious complication as sickle cell disease and requires special alertness on behalf of patients, physicians treating infected patients. However, thalassemia patients do not have the same risk of lung infection as patients with sickle cell disease. Pakistan Thalassemia Center. During the last few years, it has provided financial assistance to more than 3,000 thalassemia patients, keeping in view the importance of Thalassemia Center and to cater the patients in Pakistan, especially Kashmir and northern areas and Gilgit-Baltistan. It has Thalassemia Center have been established for free of cost treatment by Pakistan Baitul Mal, and during the year 2020, 9,330 thalassemia patients served in Pakistan Thalassemia Center, Islamabad. Now, moving on to multiple choice questions. MCQ number 1. Hydroxystasis is a clinical condition caused by the deletion of alpha genes of hemoglobin. Among a total of 4 alpha genes, the hydroxystasis is caused by deletion of 1 alpha gene, 2 alpha genes, 3 alpha genes, 4 alpha genes. Any guess? D is the right option, that is 4 alpha genes. MCQ number 2. Sickle cell disease is an inherited blood disorder of hemoglobin synthesis. Identify the correct answer from the following. Cause of mutation, the sixth position of alpha chain glutamic acid replaced by isoleucine. Cause of mutation, the sixth position of beta chain glutamic acid replaced by isoleucine. Cause by mutation, the sixth position of alpha chain glutamic acid replaced by valine. Or D is caused by mutation in the sixth position of beta chain, that is glutamic acid replaced by valine. D is the yes, D is the right option. MCQ number 3. Sickle cell disease and variants are genetic disorders resulting from the presence of a mutated form of hemoglobin. Which of the following conditions worsen symptoms associated with sickle cell disease? Decreased pH associated with exercise, increased fetal hemoglobin, increased hemoglobin C, increased oxygenation, increased blood pH. Any guess? A is the right option. Yes, A is the right option. MCQ number 4. Excess iron is stored in organs, especially liver, heart, pancreas, which can lead to life-threatening conditions such as liver disease, heart problems, and diabetes. Which of the following is most commonly characterized by iron overload? Alpha thalassemia, beta thalassemia major, thalassemia intermedia, sickle cell disease, or sickle cell anemia. Any guess? Most commonly characterized by iron overload. It is B. B is the right option. MCQ number 5. Mr. and Mrs. Ali both are positive for sickle cell trait. They went to a doctor for genetic counseling before start of a family. They were counseled about the chances of disease in their offspring. Which of the following could not be the possibility? 1 in 4 would be perfectly normal. 1 in 2 would acquire the trait. 1 in 4 would have a disease. All of the 4 would have a disease, or all of the 4 would acquire the trait. D is the right option, that all of the 4 would have a disease. This is not the possibility. MCQ number 6. A 6-year-old boy, known case of sickle cell disease, developed abrupt onset of chest pain associated with dyspnea, cough, followed by 4-day history of chest infection. He was taken to medical emergency to get prompt relief of his symptoms. What is he most likely suffering from? Acute chest syndrome, acute coronary syndrome, painful crisis, hemolytic crisis, aplastic crisis. A is the right option. A is the right option, acute chest syndrome. MCQ number 7. A child was born to a couple who were thalassemia trait positive. The newborn screening revealed him thalassemia trait. Later on, developed mild symptoms of anemia. What would be the best treatment option for him? Blood transfusion, iron chelation, bone marrow transplantation, splenectomy, no treatment required. Any guess?
C.
D is the right option, splenectomy. MCQ number 8, splenic sequestration is one of the complications of sickle cell disease that occurs when vasoocclusion occurs in spleen, leading to blockage of microvessels and accumulation of blood in spleen. Which of the following is not true about it? It is a life-threatening medical condition. It is common in adulthood. It worsens baseline anemia. It causes increased risk of infection caused by encapsulated bacteria. Any guess? B is the right option because it is
B.
most common. Yes, B is the right option. MCQ number 9. Pakistan is among the highest thalassemia burden countries in the world with 1 lakh transfusion dependent thalassemia patients. The birth of thalassemia major can be prevented if known carrier parents go for genetic counseling, prenatal diagnosis, gene therapy, stem cell therapy.
Alpha.
B is the right option, prenatal diagnosis. MCQ number 10. Infection is the most common cause of death in sickle cell disease, especially in children due to splenic dysfunction. This can be prevented by giving all of the following except penicillin, cephalosporin, pneumococcal vaccine, influenza vaccine, travel prophylaxis for malaria and endemic areas. B is the B is the right option, cephalosporin, because it is not given in the for prevention. This is the key of MCQs, and thank you.
Thank you very much, Dr. Meha. Very nice presentation, and especially you have highlighted a very important public health problem, especially in developing countries like Pakistan, and that is thalassemia. As we know, thalassemia is an inherited condition that is passed from the parents to the children's, and it is the genetic counseling as well as the family counseling, health education that has very important role in prevention of thalassemia. Other blood disorders, as you have discussed, like sickle cell anemia, they are very in a very low prevalence, and we are still having a lot of emphasis on health education while we are dealing with all these genetic disorders. The main health problem that is associated with thalassemia is building more thalassemic centers to make health policy that how to tackle the serious health condition, especially when thalassemia major is present, how the blood transfusions that should be risk free, because we know that most of the children who are thalassemic, they are getting later on infections like hepatitis C, B, and even HIV during the course of their treatment. Again, another important point is the ferritin, increased ferritin levels, as there are multiple blood transfusions, so there are increased stores of irons and the iron chelating agents that are recommended, like ferrodexamine, and that has increased the life expectancy significantly. The symptoms are fatigue, weakness, there is a yellow skin, there may be the facial bone deformities, their growth is slow, even the growth chart that has to be maintained periodically for all these children. And there may be any abdominal swelling, dark urine, and if the thalassemia is left untreated, it can cause severe condition and even death. So we know that as there are fewer red cells, so the bone marrow that is producing very few healthy red blood cells, that leads to this condition, and we need repeated blood transfusions. Having said that, we also know that there is also the moderate and the mild form of thalassemia, especially when there is a mild form of thalassemia, it is very difficult to distinguish it from anemia, especially from microcytic hyperchromic anemia, and hemoglobin electrophoresis is one of the option to differentiate microcytic hyperchromic anemia and thalassemia minor. We know that thalassemia minor that is prevalent in Pakistan, and many people they are suffering from it. As your most of the conditions that you have discussed, They are very important, but the most important disease is thalassemia, and how the government is dealing it, how the systems they are being built on it, how the health policy planning they are being done. I think of two more slides are required to highlight the importance of this very, very important disease. Overall, it is a very good presentation, very well done. And thank you, Meha, for presenting it so well. Allah
Thank you so
Hafiz.
much, ma'am. Thank you so much. Allah Hafiz.